Hello. Good evening, students. Good evening. Welcome to our class. We'll just confirm whether we are live or not. From where we are streaming, there will be some lag. So just want to verify.
Good evening. Welcome to our class. We'll just confirm whether we are live or not. From where we are streaming, there will be some lag. So just want to verify. Good evening.
Yes, I think we are live now. And can somebody also type in the chat box so that I know that the chat box is also functioning properly? Okay. Uh, okay. So, yes, I think we are live and streaming is proper. So, yes, thank you very much. So, chat box also functioning. Yes, so welcome all of you to our session for the upcoming FMGE examination. We are going to solve some very important hot topics and MCQs which are very going to be likely even this year. If you have seen the lectures, the vitals or each and every question were from the lectures which I had taken in this platform. Okay, so FMGE July exam, all the questions were there from my lectures and we have done a revision of that also. And welcome all of you. Just a quick couple of things. All of you are aware of Unacademy NEET PG. Okay, point number one, this is extremely important. Vitals. Okay, NEET PG vitals, complete set of pre-recorded lectures. To get the subscription, please use the code mentor. These are all the top 19 teachers. You will get everything: question bank, test series, 800 hours of comprehensive studio recorded lectures. Okay, all of you do participate. When I ask you the MCQs, participate in the polls also. And this is a very important on the Unacademy platform. These are all the special classes. So you may want to make a note of these special classes starting from 25th August till 31st August. All the different topics: pediatrics, biochem, myself, OBGY, pharmac, ophthalm, biochemistry, pediatrics would be there for all of you. These are special classes on the Unacademy platform. So do participate in them so that you will get very good information regarding your upcoming examination. Okay, and this is the ultimate revision batch which is now available only at 6,600, 150 hours of live classes and also rapid revision and MCQ discussion for target 150 for the upcoming FMGE. All the best teachers including me will also be there taking this classes live. So please use this code, and the code remains the same, MENTOR. So if you haven't taken the subscription till now, just you can take for this 3-4 month subscription till your December exam for the best outcome. Okay, and this is also valid till 25 August. You are getting 20% off. That's the highest discount which you are getting. Again, the code remains the same, MENTOR. Okay, so use all this to make use of this offer and take use of this lecture. They are very important. This, okay. And iconic, the last thing, iconic subscription is what I was telling you, the live classes. It's a combination of live classes, mentoring session, notes, as well as vitals. Okay, so you will get everything. You will get live classes, you will get recorded content, live plus vitals. Okay, and the code remains the same, mentor, MENTOR. Okay, mentor is the code for this iconic subscription, and along with that we are also having mentoring sessions. Okay, so with this as the background, and all of you know the other features: live classes anytime, anywhere, any device of your choice, notes, question bank, test series. Okay, so with this as the background, let us begin our discussion. I want all of you to participate in the, when we ask the questions, right, wrong does not matter. We'll try to cover some 15 MCQs in this 1 hour time. Okay, so the first question for the day, very important topic. I have arranged the question topic wise. So the first topic is PPH. So there will be 2-3 questions related to PPH. These are all the short topics, you can say, or hot topics based on which surely you get MCQs. Anybody with the answer? PPH associated with all of the following except, anybody? Yes, please all of you participate in the answering session so that I'll make it like an interactive session. Okay. Yes, anybody with the answer? PPH is associated with all of the following except. I want all of you to participate. Okay, my cute buddy is saying 3. Renu Singaria, option D, very good. Baljinder K Sahi, number 4. Okay, so excellent all of you. So please be, even if you're wrong, that's not a problem. So all of you please pay attention. Can anybody tell me the types of PPH? So PPH is postpartum hemorrhage. It is of two main types. It is either atonic PPH or traumatic PPH. Okay, atonic PPH is mostly 80% of the time. Traumatic PPH is remaining 20%. So if you get an MCQ where what is the most common type? Atonic PPH. And atonic PPH, why would I get? Okay, there's another way of remembering this also, the 4 T's: tone, trauma, tissue, thrombin. Okay, many people remember it like this. Tone is this atonic only, tone. Trauma is what I told you, 4 T's: tone, trauma, tissue matlab retained tissue, and thrombin matlab DIC, thrombin problem. Okay, so that's also, if you remember, that's okay. So keep in mind, why should there be atonic PPH? Atonic PPH can happen because of over distended uterus. So can somebody in the chat box give me examples of over distended uterus? Can somebody give me examples of over distended uterus? When the uterus is over distended, it will not contract after delivery. So any idea what are examples of over distended uterus? Yes, anybody? Over distended uterus क्यों हो सकता है? So over, very good, Renu, Rajani, Ram, excellent. Okay, so twins, polyhydramnios, big baby, macrozomy, all this is over distended uterus. Excellent, all of you. Next, remember, APH predisposes to PPH. That means if there is abruption or placenta previa after delivery, there can be PPH. And hypertensive disorders and preeclampsia, again there is a chance of having PPH, along with of course past history and multiparity. Okay, if the lady has delivered many times, grand multipara, all that, there is risk of PPH. So now if we go back to the answer, yes, APH, it is all except APH predisposes to PPH. So abruption is example of APH. Multiple pregnancy is over distended uterus, I just explained to you. And anybody, why in HELP syndrome? What is the full form of HELP? Hemolysis, elevated liver enzymes, and LP is low platelets. So because it is low platelets, there is going to be more bleeding, and HELP is besides the complication of preeclampsia, that the blood pressure would be high. Okay, so all this we discuss in detail in our actual classes. So 1, 2, 3 all can risk, there is a risk of PPH. IUGR is a small baby. So IUGR का opposite of IUGR मतलब what I told you, big baby, macrozomy or macrozomia is responsible for development of PPH because it's a big baby. So gestational diabetes, your GDM, polyhydramnios, macrozomy, all that. Okay, so IUGR is the answer over here. Okay, so good all of you for participating, and like that give me one. And traumatic is, there is a trauma, the uterus has very well contracted after delivery, the uterus has very well contracted, but there is bleeding from the all the cervical tear, vaginal tear, all that. Okay, so that is the traumatic PPH. Now anybody, PPH treatment with all of the following except, anybody? Next MCQ. Again, all of you do please participate in the poll, in the MCQ. Yes, I want the answers. Please keep on typing in the chat box. Right, wrong does not matter. Okay, Dr. Rajani is saying option 4. Anyone else with any other answer? Baljinder Sahi 4. Yes. So anybody, what is the first drug of choice? What is the first drug of choice for PPH? Anybody? Oxytocin. Oxytocin is considered the first drug of choice. Can also somebody tell me for PPH, okay, for both prevention and treatment, can somebody tell me how much dose do I give? What is the dose of oxytocin? Very good, Yatin Puri Rajan. Yes. Anybody? How much oxytocin dose do I give? Dose they may not ask you, but just for my love for the subject, कितना oxytocin दे सकते हैं? when I want to treat PPH. I'm not talking about prevention. For treatment of PPH, how much oxytocin will I give? 4 to 12. Rajani Ram, that 10 is for 10 units is for prevention. Okay, so 20, 30, 40. Very good, Shweta. Very good. 5 to 10. Okay, so 10 units. 10 units, many of you are typing in the chat box, correct. 10 units is for prevention of PPH. That is when I do active management. Very good. Okay, that time we prefer 10 units intramuscular. Okay, when we want treatment of PPH, we prefer 20 units in IV infusion. Okay, never give IV undiluted bolus. Okay, IV infusion, that means always IV diluted infusion is very, very important. Never give IV bolus. Okay, so oxytocin, of course, I can give. Methergin or methyl ergometrin also can be given. If after this the bleeding is not coming under control, definitely we move on to the prostaglandin, the second line treatment if oxytocin. So which are the prostaglandins? Anybody, can you tell me which types of prostaglandins? There are two prostaglandins which I give for PPH management. PG, which one? Very good. PGE1, which is misoprostol, and PGF2 alpha, PGF2 alpha, which is carboprost. Okay, so PGE1 can also be used, PGF2 alpha can also be used. We discuss all the details about the dose, all that in the lectures also. Packing can also be used. Okay, intrauterine packing, condom, tamponade packing, condom pressure we give. And lastly, these are uterine compression sutures. Okay, when all the methods fail, there are the stitches which I place on the uterus. It goes from aage se, then from behind, then from front. They are like suspenders and you tie. So they are uterine compression sutures. The one of the example is Belin suture. Okay, uterine compression sutures. The answer is Y, option number 4. Anybody? I'm so happy I teach this. It was a last year MCQ in the NEET PG because students, we ligate the uterine vessels, we ligate the uterine artery, and still if the bleeding is not getting under control, I will go and ligate the internal iliac vessels. Okay, we will ligate the internal iliac vessels, but which division, all of you? The anterior division. Yes, no, but a lower limb blood supply is from the external iliac. Okay, external iliac continues this femur. Okay, Renu, keep in mind. Okay, so anterior division has to be ligated because uterine artery is a branch of anterior division. So stepwise devascularization. Yes, very good, Shweta, and very good, Renu and Rajani, all of you correct. Yes, okay, so keep this in mind, posterior division nahi hona chahiye, and that becomes the answer. Moving on to the third question, again in relation to PPH, all these questions could be asked to you. Methyl ergometrin absolutely contraindicated in which of the following for PPH? Which patients I will not give methergin or methyl ergometrin? A, B, C, D. Very good. Okay, so methyl ergometrin is mainly, remember that whenever the fourth option is all of the above, na, students have a tendency to mark that as the answer, but no, that's not the answer. Okay, why? Because a lady who is multi-paras, I told you, more chance of having PPH. So in a multi-paras patient who is delivering second, third, fourth, fifth time, multi-paras patients, we are talking about management of PPH. Okay, that means after the baby delivery. Remember students, methergin can never be used for inducing labor. Methergin can only be used after baby delivery. Is this understood to all of you? While the baby is inside the mother, I cannot give Methergine, because it causes both upper and lower uterine segment contraction. It causes both the upper segment and the lower segment to contract. Anybody by chance, just for your reference and knowledge, if the baby is inside the uterus, and if I give Methergine, what will happen? This is the uterus, this is a big baby, say 34, 35, 36 weeks, and by chance if somebody gives Methergine, what can happen? Calamity. What can happen? Anybody? What can happen if by mistake Methergine is given while the whole baby is inside the uterus? What can happen? Think. Okay, so both upper and lower uterine segment will contract together. Not only severe fetal distress and the baby can die, it will cause a strong tetanic contraction. Very good, Pushpender Fauzdar. Rupture uterus, this whole big gravid uterus will contract against the closed cervix, and there would be rupture uterus. You might have to go to jail for double murder. Okay, mother dead, baby dead. Okay, rupture uterus, mother dead, baby dead. Okay, so never give Methergine for inducing labor. That's why the question is also for PPH management. So multipurpose patients, of course I can give. Previous LSCS is understood. After baby delivery in previous LSCS also I will give. Okay, eclampsia is the answer. Can anybody tell me why? Because methyl ergometrin is a vasoconstrictor and it will increase the blood pressure. It will increase the blood pressure, and therefore in hypertension, remember I tell this to all my students, 2H. Second is what? Heart disease. Heart disease patients also I will avoid Methergine. The reason being, in heart disease, increase in preload, increase in afterload, and suddenly the heart disease patient can also die. So heart disease and hypertensive patients, which is your eclampsia as well as preeclampsia, Methergine is absolutely contraindicated. Is this understood to all of you? Okay, so eclampsia is the answer. Moving on to the next thing. So remember the students about the heart disease and hypertensive disorders. We will absolutely not give methyl ergometrin. Moving on to the next topic. Yes, again a very hot topic. Surely questions are coming on this. Trisomy 21 antenatal detection. Anybody? Which of the following is not true? So there are various tests which are performed. We'll discuss that in detail. Dual marker, triple marker, all that. Can anybody tell me the answer to this? Okay, Rajani 3, Pushpender 3, Renu Singh 3. Perfectly correct. I come back to this question. Don't worry, I come back to this answer in a minute. Why? Because I want to ask you one more MCQ now. Dual marker test. What is this test? Anybody? Dual marker test. Two things. What is the test for? And when do I perform this test? And what are the two markers which I do in this dual marker? Is it HCG alpha fetoprotein? Is it alpha fetoprotein inhibin A? Comma is missing over here. HCG PAP-A, very good. No Ruterna destiny, not A. Okay, Rajani correct. Yes, Dr. PK A nahi. Okay, so for dual marker test, very good. The answer is HCG and PAP-A. HCG is human chorionic gonadotropin, and what is PAP-A? PAPPA, pregnancy associated plasma protein A. I'm giving out the full form. PAPPA, pregnancy associated plasma protein A. Okay, so that is the two things what I measure on. How is the test performed? On maternal serum. Okay, mother's blood. This is a test done. It's a screening test for Down syndrome. Anybody? At what weeks of gestation do I do this? When is this test done? Very good, Pushpender. It is done towards the end of the first trimester, 11 to 13 weeks. Okay, 11 to 13 weeks, 11 to 12 you can remember in the exam, or 11 to 13 weeks is very important. So dual marker test is a screen. Point number one, it is a screening test. Yes, all of you. Wait, Shweta, not 9 to 12. Okay, yes, 11 to 13, 13.5 chalega. Okay, and remember students, it is a screening test. It's not a confirmatory test, it is a screening test, which is a confirmatory test. All that we'll discuss on. Now suppose if the baby has Down syndrome, what happens to the HCG values? Sir, HCG is higher than normal and PAP-A is lower than normal. Please keep this in mind. Please keep this in mind. Okay, sir, HCG and PAP-A, HCG is higher than normal, PAP-A is going to be lesser than normal. So this is very important, and therefore now we know. And one more thing, so this is all about the dual marker test. The previous answer I'm still coming to it in a minute. Now one more important MCQ in this topic, quadruple marker test. When do I do it? I'm so happy. Go back and check this MCQ I had discussed in the YouTube revision session just before the FMGE exam on the Unacademy platform only. And the same question came in the FMGE exam. Yes or no? Thumbs up those who gave the exam. This question had come in the recent FMGE examination. Yes. Remember, quadruple marker test is done in the second trimester between 16 to 18 weeks. Okay, not 22 to 24. That's too late. It's a screening test. Quadruple marker test as well as triple marker test. Timing is the same. Okay, quadruple marker and triple marker, answer is 16 to 18 weeks. 11 to 13 we already told you. 11 to 13 we are going to do the dual marker test. Okay. And what are the markers in triple marker test? HCG, alpha fetoprotein, unconjugated estriol. Keep this in mind. In triple marker, 3 components are done again on the maternal serum: HCG, alpha fetoprotein, unconjugated estriol. And anybody, what happens to the values again over here? HCG is higher than normal and other two are lesser than normal. Is this understood to all of you? And therefore, so remember, quadruple marker test second trimester, and therefore now we come back to this MCQ. PAP-A will be decreased. Yes, it is. Which of the following is not true? Maternal alpha fetoprotein is going to decrease. Yes sir, I told you it is going to decrease. And what is this anti-nuchal translucent? We'll discuss that also. That is, yes, going to be more. So the answer is, you can see for yourself everywhere. HCG kahan pe tha? HCG higher than normal. Look over here, HCG higher than normal. And therefore that is the answer, students. Option 3, that HCG cannot be lesser. HCG will be higher than normal. Increase HCG if the baby is having trisomy 21. Okay. Lastly, what is this anti? Anybody? Again, very popular. What is anti? What is anti? Very good. NT stands for nuchal translucency. Okay, not nuchal fold thickness. Okay, nuchal translucency. And anybody with the value, it's at the nape of the neck, at the baby's nape of the neck, there is a this. Yes, very good. It should always be less than 3 millimeters. So it's on ultrasonography. If the NT is increased, example I am just giving, 4 millimeter, 5 millimeter, then the baby may be having trisomy 21. It's a marker for trisomy, not neural tube defect, beta Renu. Okay, it's a marker for Renu. Remember, it's a marker for Down syndrome, trisomy 21. Okay. So please, yes, aneuploidy, correct, perfect. So that's the answer, that NT will also be increased. Yes, so the answer is option number 3. HCG will not be lesser, HCG will be higher than normal. Okay, moving on. So all these 3 MCQs we've discussed. One more important MCQ. Identify this image based MCQ. So image is being shown to you. Okay. What is this image? You can, yes, this test, this procedure, what is this procedure what we are talking about? Anybody? This is, if you see, a pregnancy is there, ultrasonography probe is used, and yes, can anybody, if you zoom and see this, yes, actually it is giving away the answer, because we can see the, what is written over here, amniotic fluid. So we are poking in a needle around the baby. See, the needle is stopping over here. Okay, needle is in the Lycra pocket, it's not in the, it's not touching the baby. Okay, and perfectly correct, the procedure is amniocentesis. Okay, for detection of trisomy 21, what will I do with amniocentesis? Anybody? We do the karyotyping. So can anybody tell me, is this a screening test or a confirmatory test? Is this a screening test or a confirmatory test? Karyotyping, yes. So please understand, karyotyping is a confirmatory test. It is a confirmatory test, 100% confirmatory for any chromosomal anomaly or any trisomy. It is a confirmatory test or diagnostic test, and it is done again at around 15 to 18, 16 to 18. It can be done anytime after 14 weeks. And olden days, it was done till 18 weeks because MTP was allowed till 20. Now I can do even till 20 weeks also, till maximum 22 weeks, because the report takes 1 or 2 weeks time for the reports to come in. So 15 to 18 weeks is the best answer to mark. 10 to 13 is too early. We don't do it in the first trimester. Remember, amniocentesis is done in the second trimester. Specifically, please understand, for the purpose of trisomy 21. Okay, at 30 to 33 weeks, yeah, but the same thing. Okay, so two things better. So point number 1 is, suppose by chance, okay, Dr. Ajani, mother has got severe polyhydramnios. Okay, mother has got severe polyhydramnios, and mother cannot have breathing, mother cannot breathe, and mother is having severe poly along with respiratory breathing, respiratory distress in the mother, breathing problem, respiratory difficulty. Then also I poke in the needle like your ascitic tapping, and drain, I drain. So that is okay. So that can be done at example 30, 32, 34, 35 weeks. Okay, is that understood to all of you? So that can be done, that can be done at 30 to 34 weeks also. So that is for treatment of, that's in treatment of polyhydramnios. Of course, okay, that is only as a temporary, that is called, again you do amniocentesis to drain the fluid out. Okay, like how you do your ascitic tapping. Okay, so that is the question. For purpose of trisomy 21, your answer is 15 to 18 weeks. Okay, so moving on to the next topic, again a very hot topic, contraception. Contraception, again the MCQ surely comes. Identify this device. What is this device, all of you? And how much is the hormone released per day? The question is about per day. Very good. This is your LNG intrauterine device. LNG intrauterine device, also called as Mirena. Mirena is a brand name. So if you remember this as LNG IUD better, and it is also called as LNG 20. That is the answer, LNG 20. Yes, so it is containing hormone. 52 milligram is not the answer, because 52 milligram is the 52 milligram is the total. 52 milligram is the total LNG what it is having. Okay, and how much is released per day, 20 microgram per day. 20 microgram per day is released in the uterine cavity. It should be placed inside the uterus. It's an intrauterine device. And anybody, where do we use it apart from contraception? Where do we use it? So 20 microgram is the answer. Okay, and effective for 5 years. Anybody, where do we use it? Where do we use it? So LNG 20, that's the answer. 20 max. 52 milligram is total, and microgram per day. Very good. We use it in, apart from contraception, where all it can use, I can heavy menstrual bleeding or menorrhagia, we can use this. We can also use in treatment of endometriosis, adenomyosis, and it can also be used in prevention and treatment of endometrial hyperplasia. And it can also prevent endometrial cancer. Okay, so all these are the prevention of endometrial cancer, endometrial hyperplasia, we can use it, and heavy menstrual bleeding, we can use it. All this is very, very important role or important uses of this condition. Okay. Absolute contraindication for IUCD is, again, a very popular question for any entrance exam, whether it is INI, CET, NEET PG or FMGE. Okay, Dr. Rajani is saying option number C, acute PID. Anybody? Yatin Puri C, Renu C. Yes, now all of you have become smart and nobody is saying option D, because please remember, option D is not the answer. That's a very common tendency. Okay, whenever there is a fourth option, all of the above, student will mark that as the answer. So please understand this, that point number 1, nulliparous patients we avoid. We will avoid a IUCD, but can definitely be inserted, can be inserted. Okay, so it is not a absolute contraindication. And ectopic pregnancy, the poor IUCD has been blamed unnecessarily for ectopic pregnancy. IUCD does not lead to ectopic. Please keep in mind, IUCD will not increase the risk of ectopic pregnancy in any patient, and therefore if there is a past history of ectopic also, that is not a problem. You can use it. Acute PID, okay, acute pelvic inflammatory disease is the answer, where acute PID I cannot insert a IUCD. Anybody else? Anybody else? Anybody else where we can use this? Where is the absolute contraindication for IUCD? Can you tell me 3 more? So 3 more is, I am talking about absolute contraindication for IUCD. Point number 1, undiagnosed vaginal bleeding. If it's an undiagnosed bleeding, then I cannot use it. Of course, pregnancy we cannot use it. Acute PID, which I told to you. What else? Keep in mind puerperal sepsis. So any infection, okay, puerperal sepsis, yes, undiagnosed bleeding, and even uterine anomalies. You can see the 2 horns. Okay, the cavity is distorted. If the cavity is distorted, okay, yeah, Shweta, okay, thank you for the update. Okay, yes, yeah, wait, okay. No, so beta occasionally meeting na beta students, occasionally meeting, barrier with a backup of I pill. Okay, backup of emergency control, barrier, because a whole month taking IOC pill is may not be suitable. Okay, so uterine anomalies, again we can't put, there are, because there are double cavity. Okay, if there's a double cavity, then how can we how can we insert the cavity? Okay, and yes, cervical cancer. okay, cervical cancer, and even endometrial cancer. Endometrial cancer also we cannot insert the copper T. Okay, is it understood to all of you? And remember, following V mole, this was also asked in the entrance exam, following a vesicular mole. Okay, following a vesicular mole, evacuation, the uterus is very soft, there is very high chance of perforation, so we cannot use it. Okay, yes. Now absolute contraindication for OC pills. Anybody? OC pills, what is the absolute contraindication? Yes, so OC pills, out of this, uterine anomaly, no problem. Uterine anomaly is a problem for IUCD. So again, all of the above is not the answer. And those who are smoking cigarettes, we definitely avoid. But 4-5 cigarettes in a day, you tell the patient to stop smoking, and it is not an absolute contraindication. Breastfeeding, lactating mothers, combine. Okay, C is combine. Combine means both estrogen and progesterone. Combine OC pills, breastfeeding. Remember, breastfeeding and breast cancer, both. Okay, breast cancer, yes. If it's severe smoking, okay, more than 15-20 cigarettes per day, and if the age is more than 35 years, correct, very good. So breast cancer, breastfeeding, and your active or active liver disease, because OC pills are metabolized in the liver. Okay, so liver disease. What else? Thrombophilia, there's thrombophilia, Apla syndrome, okay, DVT, okay, DVT, thrombosis, stroke. All these patients, the OC pills are absolutely contraindicated. Is this understood to all of you? Absolute contraindication for OC pills is, so this is the answer, breastfeeding, breast cancer. Okay, moving on to the next, the drop in fetal heart rate. Yes, very good, Renu. Migraine with aura, thank you for, yes, very good, we discussed. Okay, absolutely correct. Severe migraine headache, that is when you have migraine with aura also. Okay, that is complicated migraine, again one of the, this whole list, I'm not, this whole list which we discuss in the actual classes, I'm just giving you the main list is there, one or two may more also be there. Okay, yes. What is the drop in the fetal heart rate which I see on cardiotopography or NST with a placental insufficiency? Placental insufficiency. Is it early? Many of you are telling early deceleration. Somebody is saying late. Yes. Is it very good? So with placental insufficiency, what is, yes. So please understand, students, again we can get a match the column. Early deceleration is seen with head compression. Early deceleration is seen with head compression. Okay, late deceleration is the answer. Late deceleration is the answer. Late deceleration. Late deceleration, you get a, is seen with uteroplacental insufficiency, or basically that indicates fetal distress or fetal hypoxia. And anybody, when would I get a variable deceleration? Variable deceleration is seen with cord compression. So very important, cord compression. Okay, cord compression. is the giving rise to variable. So this you can also get in match the column kind of an MCQ. And prolonged deceleration, any deceleration lasting more than 2 minutes. Okay, so this is a virgin MCQ, will not be asked to you, will come in, not yet asked. Any deceleration which is lasting for more than 2 minutes. What am I saying? That suppose the heartbeat goes down, and then the heartbeat has gone down and then it comes back to normal. This is suppose say more than 2 minutes, then I call it as a prolonged deceleration. It can be seen with cord like severe fetal distress. Okay, so like example, you can get it with eclampsia, eclamptic convulsion, cord prolapse, tachysystole, excessive contraction, all that you get anything, severe fetal distress, abruption, you can get a prolonged deceleration. Okay, when there is a deceleration lasting more than 2 minutes. Okay, yes. Now again, a very popular MCQ. I'm so happy with this every year, and this came in the recent AIMS exam also. All are components of BPP except, anybody? Components of BPP except. Yes, anybody? So what is it called? Manning's biophysical profile, BPP. Totally there are 5 components. Anybody, how is the BPP done? Very good. So please understand this, that anybody, this fetal kick count, NST is a part of it. Fetal kick count, who will count the fetal movements in this fetal kick count? Husband, wife, mother, doctor, intern. In this fetal kick count, who counts the movements? Anybody? Mother, father, intern, neighbor. Yes, anybody? If you get an MCQ like this, mother, father, intern, doctor, okay, or the neighbor, who will count them? Okay, very good, all of you. So mother, okay, mother counts the fetal movement in the fetal kick count. So that is the answer, that in fetal kick count you tell the patient or the pregnant lady to count the fetal movements. We tell them that after major, okay, so like example, in 12 hours, okay, like we can say 9 a.m. to 9 p.m. there should be, in 12 hours time there should be at least 10 movements. Okay, or another is like breakfast, lunch and dinner, there should be three movements after each major meals. That also is okay. So fetal kick count is where the mother counts the fetal movement at home. BPP we do NST, we look at fetal tone, and here we see the fetal movement, and that fetal movement is counted by who in BPP? Chalo, in BPP the sonologist. Okay, the sonologist or the radiologist or the person who is doing ultrasonography. Is this understood, my dear students? So fetal tone is a part of it, fetal breathing movements, NST is of course a part of it, and the next is the fetal movement. So there is fetal movement in BPP also, but that is counted by the radiologist. The sonography has to be done for 30 minutes. There should be at least 3 distinct movements. Is this understood to all of you? Okay, and the last is the Leica pocket. So I hope this is absolutely crystal clear. Don't make a mistake in this. Moving on to the next question. Very important. Ultrasonography, the earliest USG sign of pregnancy is which one? So whenever there is a pregnancy and I want to when if I do the ultrasonography, which is the first sign or the earliest sign? Yes. Okay. Everybody saying 2, 2. Okay. Anybody? Option number 1. Option number 1 is a sign of what? Yeah, 4 weeks were thoda sa early. 4 weeks ke thoda baad. Okay. 4 weeks not be early. 4 weeks few days. Okay. So 4 weeks 2 days and 4 weeks 5 days. Okay. So with a newer machine, 4 weeks 3 days or 4 weeks 5 days. Perfectly. Okay. So please pay attention, all of you. Whenever the lady is pregnant and when you look inside the uterus, the first structure what we always see is the gestational sac. Your radiology teacher will also show you the details. Okay, we show the actual picture also in the classes. Okay, so this is the gestational sac which is seen. Yes, we prefer a transvaginal sonography. Okay, at 4 weeks 5 days. Newer machine 4 weeks 3 days also sometimes we can see a gestational sac. Yes, normal. Okay, it is well circumscribed. Okay, and with a thick echogenic ring and the double decidual sign. After 2-3 days, inside this, anybody want a second circle in circle. After 2-3 days, inside this outer circle, there is a yolk sac. What is the second structure what I see inside this? Anybody? Very good. This is a yolk sac, and then attached to the yolk sac I see the, what do we see next? We see the fetal pole. Okay, fetal pole matlab baby. Okay, the fetal pole is measured in what? Crown rump length, and inside the fetal pole is a radiological term, and inside the fetal pole we also see the baby heartbeat flickering. Okay, that is called as fetal cardiac activity. That tells me that this is a, that tells me it is a live pregnancy. It is a live pregnancy. Okay, so the answer is that the first sign is gestational sac. I'm telling the sequence of event. Next comes the yolk sac, then comes the fetal pole. So the answer is this. By the way, free fluid in POD is a sign of ovulation. Okay, mid-cycle. If in the middle of the cycle around 13-14 day, if I see some free fluid, it is also a sign of inflammation, infection. It would also be seen in ruptured ectopic pregnancy, but all free fluid is not dangerous. Free fluid could also be seen as a sign of ovulation. Normally all patients mid-cycle there, because when the follicle will rupture and the follicle will collapse, the follicular fluid comes in the pelvis. Okay, I hope that is absolutely crystal clear to all of you. Moving on to again a very important MCQ, tubal patency. So gynac, we did a lot of obstetric MCQ, now we're going to gynac MCQs. What is the best test for tubal patency? They have not asked. Many students make tubal pregnancy mark karte hain पढ़ के. It's not, I'm not talking of tubal pregnancy. Tubal patency means what? Is tubal pregnancy and tubal patency same? Anybody? Just by the way, anybody? Tubal pregnancy means what? Tubal pregnancy ke liye what is it? It is ectopic pregnancy. We prefer sonography. Transvaginal sonography will have to be done. And if doubtful, we might do serial beta HCG. Okay, you do beta HCG, you repeat after 48 hours. Okay, so transvaginal sonography will detect ectopic pregnancy, and sometimes if required you take help of beta HCG. That is tubal pregnancy. But tubal patency is of course completely different. It is done for infertile patients. So what is the answer over here? Okay, so HSG is a contrast X-ray, and it is generally preferred like a first. It's a X-ray, but it can have its false positive, false negativity, and it is of initial investigation. Okay, it is initial. Please understand, surgery I don't do first. So HSG is considered like a initial investigation for tubal patency. Okay, saline infusion sonography, SIS means saline infusion sonography. Okay, here what is done is that a saline is injected into the uterus. Okay, with a catheter, there's a uterus, you put a catheter and then you inject the saline, and then the movement of the saline, and then if the saline you push, you get free fluid in the pelvis. So that is called as sonosalpingography. Okay, and hysteroscopy is not at all for tubal patency. We'll discuss hysteroscopy in the next MCQ also in a minute. The answer is laparoscopy. Anybody, what do I do in laparoscopy? Any idea? What is the answer? Laparoscopy. And what do we do? While I do laparoscopy, what will I see? Anybody? I do the laparoscope. What is laparoscope? Sir, you put in a telescope through the abdominal wall. Many students are totally confused. Laparoscopy, you put in a telescope through the anterior abdominal wall and see the pelvis. So you see the uterus, you see the fallopian tube, okay, you see the ovary, you can see any other problem outside in the pelvis, adhesions, endom, all that. Okay, and then what is done? Chalo, anybody, what is done for this tubal patency? What is done? Something else has to, one more step has to be done. Very good. We do a methylene blue. We take a methylene blue dye. I'm going to show you the picture. Okay, methylene blue dye. So what will happen? All of you pay attention. What will happen is the assistant will put a methylene blue dye through the cervix. Through the cervix, the methylene blue dye will be pushed into the uterus. So common sense, the dye will enter the tube, and with your own eyes we can see the blue color dye coming out of the fallopian tube. This will confirm, tell me, that the tube is patent. Is this understood to all of you? This is called as chromopertubation. Okay, chromopertubation. Is this understood to all of you? And yes, perfectly correct. It is also for diagnosis, perfectly correct. We can break some adhesions if there is there. You can remove a fibroid and treat it also. Okay, so one more while we are over here. Yes, can anybody identify this image based MCQ also? We'll have time for one or two more. Yes, what is this MCQ showing me? Then I come back to the answer in a minute. Okay, what is this picture showing you? Perfectly correct, students. This is a laparoscopy view. Okay, this is the uterus. This is the uterus what we are seeing. Okay, this is the ovaries. Okay, this is the ovary what we are seeing. This is the pelvis. Okay, pouch of Douglas, I'm writing pouch of Douglas, and this is the instrument. This is the fallopian tube. Okay, and we can see this blue color. This blue color is the methylene blue dye. Okay, so this is the test which we were talking about. This is not a sonography. This is not a tubal ligation. In tubal ligation, we have to ligate the fallopian tube with a band. This is the laparoscopy chromopertubation. Definitely this MCQ is coming in the upcoming examination. Okay, with hysteroscopy you don't use a methylene blue, and Rubin's test is the outdated test. We used to put some air. Okay, used to put a air and hear some hissing sound, all that, so that nobody does. Used to put a stethoscope on the patient's abdominal wall, push some air into the cervix and hear for the hissing sound. So all that is not done. Okay, so this is a laparoscopy view and laparoscopy chromopertubation, or basically it's a test for tubal patency. Okay, and you see both left and right side fallopian tube. So this image, keep in mind, is a very, anytime when you see laparoscopy and a blue color dye, that is your tubal patency or laparoscopy chromopertubation. So coming back to this answer, this is considered the best investigation. Laparoscopy with a methylene blue, or as I told to you, chromopertubation, what I showed you. Okay, chromopertubation. Okay, because your sonography and HSG will have some false negativity and false positivity. So there is not confirmatory. Confirmatory is with your own eyes we can do laparoscopy. Now can anybody tell me what is the difference between hysteroscopy and laparoscopy? And that is our next question, students. Hysteroscopy is for all of the following except. So what is the hysteroscopy for? Hysteroscopy is for what? Any idea, anybody? What is hysteroscopy done for? So hysteroscopy, sir, is putting in a telescope inside the uterine cavity through the cervix. Through the cervix, you will put in a telescope to see the, no beta, not looking into the abdomen. Okay, that's the, Dr. Rajan, that's the difference. Okay, hysteroscopy is to see the uterine cavity, anything to do with, mainly remember cavity, not abdomen. Okay, Rajan, you see the difference. Laparoscopy may I go through the abdominal wall, so this what I have shown you is a laparoscopy. Okay, and you can see the tubal patency, if there's any chocolate cyst, if there's any powder burn spots, endometriosis, what all you get, red spots, blue spots, all this we discuss in detail in our actual classes. If there's any fibroid on the outside of the uterus, okay, subserosal fibroid, all that I can see with laparoscopy. Okay, so hysteroscopy में अपने को क्या क्या पता चल सकता है? Anybody? What all things I can come to know inside the, yes, hysteroscopy is inside. So all of you tell me, suppose if I see the hysteroscope, so hysteroscope is inserted, so this is the hysteroscopy, we enter through the cervix, we enter. Okay, through the cervix we enter, and all of you look on the board and tell me, okay sir, suppose there are, yes, there is a polyp, there is a endometrial polyp, or there could be a submucosal fibroid, or what is this condition called as? Anybody? Suppose I see there are adhesions between the wall, what is it called as? Excellent, Shweta. Okay, so we can see a polyp, okay, polyp, fibroid, but which fibroid? Submucosal fibroid. All this I can come to know. And lastly, even septum. I'm so happy I teach this every day. So again, the MCQ in the last year's NEET PG, septate uterus. Remember, septate uterus, the outside of the uterus is normal. If I see the uterus from outside, the outside of the uterus, outer surface of the uterus, outer uterus is normal. When in septate uterus, in a septate uterus, because septum is protruding within the uterine cavity. So this what I've drawn is the septum. And what is the advantage of hysteroscopy? I can, again, it is both diagnostic and therapeutic. Very good. This intrauterine adhesions is also called as Asherman's syndrome. Again, last year's MCQ, Asherman's syndrome. Okay, so all these are very, very popular MCQ. Now if I go back to my question, yes sir, hysteroscopy is for all of the following except, yes sir, Asherman's syndrome, of course I can come to know, because Asherman is intrauterine adhesion. Very good. Anybody wants the answer? Endometrial polyp, I told to you, polyp I can come to know, and septate uterus also I can come to know. Very good, doctor. Why is endometriosis the answer? Because endometriosis is presence of endometrium outside the uterus. Endometriosis, everything is outside the uterus, in the pouch of Douglas. Is it clear? Or the uterosacral ligament here. So endometriosis may you see everything over here. You get this powder burn spots, matchstick burn spots, okay, powder burn spots. You get a chocolate cyst. Okay, I'm writing CC. All that is signs of endometriosis. Is this understood to all of you? So for endometriosis, I require to do laparoscopy. Septate uterus, polyp, Asherman, for all of them. Hysteroscopy advantage, all of you, is not only for diagnosis. All of you pay attention. We can also do the surgery. Is this understood to all of you? All of you can see this. We can see, we can cut the fibroid. क्या हो गया? Hysteroscopy, myomectomy. I can break, see I'm breaking the adhesions. Can you see I'm deleting? Okay, so this is called as hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis. I can cut the polyp, hysteroscopic polypectomy, and also cut the septum and make the cavity normal. So all the pathology which is within the uterine cavity can be managed by doing a hysteroscopic surgery, like a polyp or a fibroid or Asherman syndrome or a septate uterus. Is this understood? So that is very, very important. So thank you so we have got so many MCQs. I hope it was a very, very helpful session for all of you, and do not forget to join me on a so do not forget to join me on, download the Unacademy app for sure. Please use the promo code mentor to get the subscription of your choice, and do not forget to make use of this code to get the extra discount. And also this pack which is starting now and on 26 Saturday, all of you, Saturday evening at 5 p.m. Saturday 5 p.m. I am going to have one more free class. It's a special class, free for all, where we will be discussing the MCQs that is on the Unacademy platform. So I see you all over there. Okay, yeah, we'll discuss. Okay, so Subir, so give me some, we'll discuss that in the upcoming classes also, your doubt. Okay, so special class is there on the 26th, which is a Saturday at 5 p.m. and I hope all of you will be there. Okay, no beta, Saurav Singh, for endometriosis, yeah, laparotomy was done in the past. Okay, Saurav, endometriosis, laparotomy was done, but now we do laparoscopy. So laparoscopy is an eligible choice for endometriosis. Okay, so bye bye, best of luck. Thank you very much all of you for coming in today, and I see you on Saturday 5 p.m. for one more fascinating class. And do not forget to join in with the promo code of mentor. Bye bye, best of luck. Thank you.